My talk is on kind of what I think is here already, but perhaps an emerging idea that to use radiology to make definitive diagnosis regarding like histology, and in this case, I'll use kidney tumors. The concept is not a foreign one with the advent of PSMA PET scans for prostate cancer. So the era of molecular imaging is here, using molecular knowledge and creating sort of imaging tests related to what we know about molecular sort of information. So, patient with a kidney tumor, small kidney, small renal mass, 3 centimeter mass, et cetera, there's still a lot of gaps in our knowledge. And we know that we take out a lot of benign kidney tumors because there's a growth and, there's some limitations to the diagnostics. And at least in this country, there's been an increase in the proportion of masses removed that are benign, as shown by this study from the University of North Carolina. Biopsy certainly is an option and has, I think, become more accepted, more in the armamentarium. But this is from a systematic review that we did not too long ago, looking at the diagnostic accuracy of a biopsy. And certainly, if you do a biopsy on a kidney tumor and you get cancer back, you can hang your hat on that result. But if you get a negative biopsy, there's still a false negative rate that is not insignificant, and there remains a non-diagnostic rate. You get sort of a biopsy that's just not diagnostic. You also have this oncocytic dilemma where they tell you there's oncocytic cells, could be an oncocytoma, but could be RCC with oncocytic features. So certainly not the end-all be-all in terms of accuracy. And there's anterior tumors like the one shown in the middle there that is hard to access with a needle. Maybe it's too small to access. But certainly the side effect kind of profile or the adverse event profile is reasonable. So I think biopsy is certainly a guideline, acceptable sort of risk stratification tool, but invasive and has limitations. I think that's kind of my point with this slide. We also have a lack of accurate imaging for metastatic cancer. So if kidney cancer for staging or for metastatic disease, conventional imaging is not very good. The conventional PET scan, which is the FDG PET based on sort of sugar metabolism, isn't good and doesn't even have a role, honestly, in the staging of patients with kidney cancer. And also, we're using all these very cool, medicines that work on the vasculature. Now we have immunotherapy. Could imaging even help us sort of show a early response or predict response in some ways? So a lot of cool things, I think, that we could do maybe with imaging. And I'll use this talk to sort of maybe overstate a little bit that radiographic biopsy is already possible, to be kind of provocative. And for localized disease, sure, we use cross-sectional imaging, CT and MRI, and you can glean a lot from those. But more importantly today, I'll talk about sestamibi SPECT-CT imaging as a molecular imaging agent, as well as carbonic anhydrase 9, CA9 imaging. It's a molecule that's expressed on kidney cancer, and also show you how PSMA PET can actually image kidney cancer, maybe even better than prostate cancer. So case one, 79-year-old male, with an eGFR 45, so sort of, not great kidney function, presents with a 9-centimeter incidental tumor. There's, you can see the tumor there. There's some central kind of stuff happening. Could it be necrosis? Could it be a scar? Who knows? It's just an MRI. The patient had a mitral valve replacement, is on Coumadin. And this is a highly avidly enhancing mass with a central, hypodensity. So certainly you look at it and you say, it could be a big kidney cancer. It could be potentially an oncocytoma as well. So, at Hopkins, sestamibi SPECT-CT has become sort of a standard imaging agent. Maybe we're overusing it for the amount of data that's there, but I'll tell you, how we do it. It's part of our EPIC sort of order sets. We just order it as a standard of care test. And this is kind of what the test looks like. You could see that in this case, the tumor took up the sestamibi and was avid. It's hot on it on the sestamibi scan. And for us, this is strongly suggestive that this is an oncocytoma, but we'll talk a little bit about data. So 3 year follow-up on surveillance based on just this scan. He's now 82 years old, plays golf. We didn't have to remove his kidney, risk dialysis, risk the morbidity of surgery. So to talk a little bit about sestamibi, initially the concept came up through a meeting. We were talking about the differences between oncocytoma and kidney cancer. And a pathologist says, when we look at oncocytomas, they're chock full of mitochondria, and renal cell carcinoma tends to be relatively devoid of mitochondria. And so we left the meeting thinking, gosh, if only there was an imaging agent that can look at mitochondria. And we ran into a young radiologist, which is kind of what happens at these academic institutions. And he says, yeah, we have a mitochondrial imaging agent. We've been using it for heart imaging, for parathyroid imaging, called sestamibi imaging. It's available in every hospital because we do stress tests with it. It's a SPECT CT, not a PET CT, so it's less expensive and ubiquitously available in almost every hospital probably in the world today. So we took some oncocytomas that were biopsy proven. We had surveillance of them, so we knew that these were not, we had high confidence that these were truly oncocytomas, and we imaged them. And lo and behold, they all, light up like a light bulb with the sestamibi imaging. And then we took some known kidney cancers that we've biopsied in different, clear cell, unclassified, even translocation, and we imaged them with the sestamibi SPECT CT, and we saw a very cold signal where the cancer is. And we thought, gosh, do we have something here? We dug a little bit deeper in, and the mechanism we think is mainly based on mitochondrial content. This is an oncocytoma under electron microscope, and you could see sort of the mitochondria on the inside, and it's just jam-packed with these mitochondria, whereas a clear cell RCC is relatively devoid. I mean, they still have mitochondria, but certainly not to the degree as the oncocytoma. Additionally, kidney cancer has the MDR pump, the multi-drug resistance pump on the cell surface, and that's why they're chemo-resistant. And it turns out that sestamibi is pumped out of the cell also by this pump. So there was all of a sudden mechanistic rationale for taking up the sestamibi in the negative membrane potential of the mitochondria, but also in cancers, pumping it out of the cells and keeping the cells clear of sort of the sestamibi. We did some staining to sort of show mitochondrial content in MDR, and we ran a small trial that was published in European Urology at the time. And for the most part, it works very, very well. If it misses a cancer, in our experience, it misses a chromophobe RCC. And as most of us know, if it's a small tumor that we're trying to risk stratify, a 3-centimeter chromophobe is an incredibly slow-growing indolent tumor. So in some ways, if it's a surveillance candidate, I kind of don't care. I mean, it's nice to know that it could be a chromophobe. But it's reassuring that when we miss chromophobes, and certainly performs very well to identify oncocytomas. And high sensitivity, high specificity. We've updated sort of results with now a couple of hundred, even more patients. And there's been some validation of the work done in Europe. There's a big trial called the MIDOR trial that's ongoing now in Sweden, and really a big literature on sestamibi imaging. And so we also know that if you look at a CT scan, and this has been long known, that clear cell RCC and oncocytomas are avidly enhancing, right? Like they pick up the dye really, really well, whereas papillary RCC is relatively hypo-enhancing. It picks up the dye, but it's borderline, right? It looks darker on imaging. And so you can all of a sudden look at the uptake of sort of multi-phase CT scan, couple it with sestamibi, and maybe even make bold statements. If something is avidly enhancing and hot on the sestamibi, all of a sudden you can maybe call that an oncocytoma for sure. Whereas if it's avid in enhancement on a CT but cold on the sestamibi, it's most likely a clear cell. And then you have the hypo-enhancing CT scan with a cold sestamibi, and that's going to be your papillary renal cell carcinoma. So incredibly cool. There is some user, to read the scans. Sometimes it's not so easy. and there are some issues with how you perform the scan. So there's a whole protocol that we've published, and I'm happy to share with your radiologists if need be. Another agent that has been used is CA9, carbonic anhydrase 9. This is heavily expressed in clear cell renal cell carcinoma. And this was the REDACT trial that was published in JCO actually many years ago. And it was a good trial. And the FDA came back and said, we want more data before we approve this agent. And then the company went under, and they never really sort of resurrected this concept until recently with the Zircon trial, where this PET agent was used. It's an antibody to CA9, and they ran this 300-patient trial. We were a site in this trial, and the results of this trial were reported by Brian Shook, who's at UCLA now, and it was a very positive trial, again, with good sensitivity and specificity. And in this case, a hot tumor would be one that is clear cell renal cell carcinoma. And this trial, I think, is going to maybe lead to FDA approval or at least a little bit more investigation of this agent. We are working on a small molecule version of the CA9. So what's available now is an antibody, and we're working with the same people who came up with the PSMA tracer to come up with a CA9 tracer. And then the idea is to do dual tracer imaging, where you can do sestamibi and CA9 all at the same time. So one injection, and it's green if it's positive on one, red on the other, and you can get a lot more information on it. And a group just published a really nice report looking at a small peptide PET agent for CA9. So you're going to see an explosion, I think, of these sort of imaging agents, but CA9 imaging important in kidney cancer and maybe coming sort of to a radiology clinic near you soon. Case 2 is a 53-year-old gentleman who had a solitary kidney, lost the kidney 10 years ago, grade 3 RCC, and lo and behold, lost a follow-up, comes back, gets a scan, and now has this tumor in the solitary kidney, and also has an adrenal lesion on the other side. And of course, the question to us is the kidney tumor a cancer, and is the adrenal tumor a metastasis? Well, let's talk a little bit about PSMA expression in cancer. And we know that PSMA stands for prostate specific membrane antigen, but it's actually a misnomer. It is actually sort of expressed in many different tumor types. And if you look at clear cell renal cell carcinoma, it's heavily expressed in the neovasculature of kidney cancer. And so again, thinking a little bit outside the box and thinking, can we use this imaging agent for kidney cancer? We took a bunch of patients who've had metastatic kidney cancer and imaged them with standard CT scan, MRI, bone scan, conventional, and they had a certain number of metastases. And then we would image them with PSMA PET, and almost always would we pick up all the sites that were picked up on conventional imaging, plus, unfortunately. So it was picking up more disease than meets the eye on conventional imaging, telling us that there may be a signal that it actually is a very good imaging agent. So in order to sort of prove that those extra spots were kidney cancer, we actually had a patient imaged with conventional images and then a PSMA PET before they passed, and they allowed us to do a rapid autopsy on them to look at all the sites that were positive on the conventional imaging and then on the PSMA PET. And on conventional imaging in this patient, 54 sites of disease were identified. And there was one lesion I'll show you. It was an inguinal node that on conventional imaging looked suspicious, but on PET imaging was not, and it turned out to be not cancer, interestingly. And then the PSMA scan identified 12 additional sites of disease, and these were very strange sites that we wouldn't think kidney cancer kind of would go in those areas. So there was an internal mammary node, there was a tricep lesion, but we were able to go after those sites and actually prove that PSMA PET scan was detecting clear cell metastases, clear cell RCC metastasis. So this is the internal mammary, this is the tricep node on this slide. This is the inguinal node. So, an enlarged node, suspicious for, cancer. but on the PSMA PET scan was not avid, and it turned out to be a necrotic inguinal node. So it worked both ways, right? So in some ways. So we did PSMA PET on this patient, and the adrenal lesion was FDG. He had a standard PET that was negative, but it was hot on PSMA PET, and therefore we said this has to be cancer, and we resected the adrenal and found that it was clear cell RCC. And then the patient had a sestamibi scan on the kidney, and it showed that that lesion was cold, and as a result, this was also removed by partial nephrectomy and was found also to be clear cell, RCC. So our patient, again, through molecular imaging, we were able to sort of unravel the situation and ended up doing, quite well. So in conclusion, I think the era of molecular imaging is here. I think we as urologists will have to understand some of the shortcomings of performance characteristics, because no test is, I'll get an email and say, we did your sestamibi and we found a false, positive, and can you explain? And the reality is, no test is perfect, right? So there's going to be performance characteristics and subtleties to all of these, much as we're seeing with PSMA PET for prostate cancer. And it's important to us, I think, to be engaged in this area of research and development, and to work very closely with our radiologists to understand what tools they have to help us make better non-invasive diagnostics. And of course, the era of theranostics is here also, the idea of harnessing these imaging agents and turning them into therapeutic agents by coupling the molecule with an alpha or beta emitter to create local radiation, which exists today with prostate cancer, lutetium-based prostate cancer treatments. So I would say sestamibi imaging and CA9 imaging are promising modalities for the risk stratification of kidney tumors. PSMA-based imaging is encouraging for comprehensive staging of advanced renal cell carcinoma, and I'd maybe add clear cell renal cell carcinoma. And I would argue that today, while biopsy is a good tool to have in the belt and the armamentarium, we do not need to biopsy the majority of tumors, because radiographic biopsy is here. So a little provocative, but I think not far from where we are today in 2024. Thank you.